Hello, everyone, and welcome to a second audio and podcast in this series. This series is titled the Busta Cap episode, and it's all about immunology, hematology, and transfusion. And this audio podcast will be an overview around the use of red blood cells, and this is basically going to be a part one. There's actually going to be an overview of different sort of focuses around the use of red blood cells, and those will be highlighted in different audios and podcasts. In the beginning, however, I wanted to provide an overview on the bases. Once again, this is the Shientist, and this is a part of a Storm Logistics production, and I'm going to start off by talking a little bit about the role of blood, the role of blood, blood transfusion. Sorry, the role of blood transfusion, and sort of how it interplays in laboratory practice. So the role of the blood transfusion laboratory is to provide an appropriate is to provide appropriate blood and blood products as determined by clinical need. The transfusion laboratory, much like the hematology laboratory, generally will receive many requests from healthcare professionals on behalf based on requests on behalf of patients who may well have issues relating to their hematology, and ultimately in relating to and in regard to the full blood count. To kind of follow on from this, I'm going to highlight that blood and blood products are derived from what are known as human donors, and generally around the world globally, generally there are blood drives in and around where for example patients who are in hospital, or who attend particular clinics for blood transfusion, for example, and also in relating to, for example, where depending on health conditions, such as, for example, where patients could be an oncology patient in relating to cancer or cancer-like circumstances or health issues, nephrology in some regards, those patients who are from or have underlying renal or kidney diseases, and also those who are obviously have hematological illnesses as well. So blood and blood components are derived from human donors based on necessity and as well as requirement, and are capable as well of transmitting many infectious agents present that may not have been or may not be detected by routine screening tests performed at the time or soon after the donation. However, that being said, and this is an underlying point I'm going to make here, that where there are blood drives, or where there are people who donate blood, for example, at donation centers and blood donation centers, what happens is that generally speaking, there is a series of questions questions that donors have to sort of go through with healthcare professionals to actually get an understanding of their general health and well-being. And at the same time, with blood donations, there are filters that are also applied, or are um, also attached, where filters are attached to actual blood donation bags. So basically, any particular sort of cells or components that could potentially be cause a health risk, or further health risk to patients. Those are actually filtered out. Now, people may also ask you may ask the question, for example, well, if someone who is donating poses a risk in relating to donating blood, then should they be donating blood in the first place, for example? Well, that being said, there are actually patients. There are members of the public, of general public, for example. Generally speaking, for example, if someone wants to donate blood, apart from going through a routine screening, and where health professionals may ask them questions, there are actually there are also pathways, as part of the pathway, where where people from the lay public, even if they have cell types, or cell types within part of their, for example, their immune system, there are actually ways that that particular cell types do not cross over in part of in part over in do not cross over in and when someone donates blood. So in the first instance, however, once again, blood and blood products are derived from human donors, and are capable of transmitting different infections agents. However, some of the in most part, most of these infectious agents that can be part of the immune system, and inherently do not cause any problems within individuals who are actually donating blood, for example. In this regard, there are screening procedures which actually can help in relating to patients. In relating to those who want to donate, and how health professionals actually can say that, for example, we are looking for donors with such and such, and at another time we would welcome those individuals, like that person who might be thinking about donating, but might have antibodies, or antibodies that might pose potential risk. Actually, at a later time, for example, they may be more viable to actually donate blood, for example, at another time, for example. So I just wanted to provide this sort of overview initially. So other considerations also include, so using the product, or the blood product, that will be most effective in producing the desired outcome. So generally speaking, red blood cells are and do fit within this particular category. And then there's the cost aspect, and then there is the aspect that relates to minimum donor exposure. Again, where minimum donor exposure is concerned, it does relate to where antibodies that are part of the immune system can cause problems, and hence why at donation sites there is more vigilance, and also part of what is known as hemocovigilance, which is basically where those health professionals who are part of getting donation requests and meeting certain blood donation quotas. For example, they are actually at the forefront in ensuring that that those who are interested in donating or want to donate blood, for example, that they can actually screen them in the appropriate way, and thus minimize risk when it comes to actually recipients who ultimately may require blood donations. And then I'm going to talk a little bit about how blood may be considered. Blood is or may be considered to be comprised of two main components, and that is there's an illustration here, or a photograph, if you will, and at the top of this photograph is where you see plasma, plasma in a blood donation bag, for example, and then at the bottom you have what is known as your red cells, or red cells, or red blood cells, or even where within red cells there are other components. But if this bag was mixed, ultimately is where you see where the bag would ultimately look all red, because in this photo example is where red cells have been separated from plasma, and so the next slide here, I'm going to talk a little bit about the cells, and from a sort of a microscopic, or what is known as, from a hematological point of view, a perspective, is what is known as from a morphological perspective. So the cells may be where, for example, the smallest cells under microscopy are actually known as platelets. Now, platelets are important for blood clotting, and in hematological terminology, platelets are also referred to as thrombocytes. Then you have white cells or white blood cells. Now, generally, their white blood cells have several different divisions as well. But generally speaking, white cells can be referred to as leukocytes, or they can be referred to as lymphocytes. Now, in this picture, in this particular illustration, the white cells, or the leukocytes or lymphocytes, as you will, are actually the darker color cell types under morphology, and then there's the red cells, red blood cells, which are also known as erythrocytes. Now, erythrocytes generally, in this illustration, like any other illustration in for example hematology textbooks, but also under microscopy, red cells or erythrocytes under microscopy from a morphological standpoint actually are not only red looking, which is obvious, but they have a sort of a concave sort of center, and basically the concave nature of red cells, red blood cells or erythrocytes actually give indication of how oxygenated the red cells are, or the red blood cells, and therefore how for hematologists and sort of blood scientists, for example, they can differentiate between abnormal and normal from looking at red blood cells, red blood cells and red blood cell indices. Then I'm going to talk a little bit about plasma. Now, in a previous slide, there was an illustration where the plasma had been separated from the red cells, and so plasma is generally a straw-colored like fluid, and it comprises mainly of water, electrolytes, and the electrolytes can include sodium and potassium, but within plasma as well is actually proteins. There are proteins within plasma as well. And so the soluble plasma proteins are primarily albumin. Now, albumin is actually the biggest molecular weight the biggest molecular weight albumin protein within general physiology. And albumin, if for example, if there's indication where albumin is leaking somewhere from general physiology, then basically it can give indication, for example, that individuals might be at risk, or have maybe at risk, but also potentially might well have a form of kidney disease, particular kidney diseases, sorry, I should say. Then there is immunoglobulins. Now, immunoglobulins are actually those types of proteins which actually give rise to where the immune system is involved in sort of repair, but also in relating to how the immune system can along with other cell types can actually act in support of an attack on foreign bodies, but also actually, as mentioned, are important in general upkeep of the immune system. And then there's coagulation factors. Now, coagulation factors are basically where in the liver, the coagulation factors are important in enabling and prompting clotting to take place when someone might be bleeding, but also where someone might be where someone may have a wound. And generally, the coagulation factors there are part of three different pathways. There's an intrinsic pathway, there's an extrinsic pathway, and then there's also a common pathway. The coagulation factors are in fact are interplayed as part of general physiology in generally so that again where someone might be bleeding, these different factors are prompted from a sort of a physiological response, so that the bleeding can stop in a timely manner. And there are ways in a hematology, from a hematological standpoint, which can help scientists to determine the time it takes for someone to stop bleeding. And obviously, the longer it takes, then at that point, it may well be that individuals might require certain blood components, namely platelets, to actually stop the bleeding. And now I'm going to talk a little bit about sort of the basis of this particular presentation, which is about the use of red blood cells, or red cell components. Now, here in this illustration is a typical bag of whole blood, or red blood cells, and this in this illustration, there's this is an illustration of an O of a bag of red blood cells, red blood cells, which are O positive, and generally speaking, these red cells would be prepared for someone who might need transfusion, and until comparatively recently, the majority of the red blood cell components provided have been used by patients undergoing surgical procedures, and I'm sure many of you who are sort of listening to this, or checking out this on this particular overview, will know that most blood components, or red blood cell components, are provided or are issued from a transfusion laboratory, have been used or have been used based on the requests from health professionals who know that their patients will be undergoing particular surgical procedures, or with those who have acute blood loss, or something that is referred to as hypovolemia. And hypovolemia means a low volume of actually those important cell types that actually help sustain life in individuals. So in those patients, red blood cells, when there is for example, incidences where there's hemorrhage, or there's hemorrhaging, or acute blood loss, hypovolemia is actually quite common in those particular incidents. So now, however, that being said, nowadays it is more common to actually use red cell components for the use of, for example, correction or correcting anemia. And actually, transfusion laboratories over time have become a bit more sophisticated in at least one area of practice, where, for example, the anemia and where anemia and hemoglobin is concerned, there's a cutoff, and if and the hemovigilance around this is where basically, for example, health professionals, for example, on the front line, even if they have a patient, for example, whose anemia is low, but it's not low enough in relating to the cutoff, then around the cutoff for the hemoglobin, then transfusion scientists hematologists, hematology scientists generally will not actually issue blood because basically, for example, there may well be someone else out there who might be in more dire need of the red blood cells at that time. So generally, it is more common to use red blood cell components for the correction of chronic anemia, but also causes that relate to hematological disorders and or patients with special needs, such as oncology or renal or those undergoing, for example, renal dialysis or hemodialysis, and because with hemodialysis patients, for example, the artificial kidney attached to a dialysis machine, for example, holds the majority or a large volume of the patient's whole blood. Now, in the artificial kidney, there is a sort of a susceptible nature where, or a vulnerable nature where a lot of blood from the general physiology of an individual is in part with or separated, let's say separated into the artificial kidney linked to a dialysis machine. So if patients, for example, on dialysis feel apart from part of the diagnosis of renal patients is what's known as a low hemoglobin. Apart from that, there's also the vulnerable nature of where the hemoglobin and the blood volume in a dialyzer attached to a dialysis machine, or where patients are attached to a dialysis machine, can actually cause problems to the patients where the blood volume drops even more so. Thus patients on dialysis are under this particular category whereby for example, they may require blood components and red blood cells in particular incidences. However, that being said, again, there is a hemovigilance aspect from hematology and transfusion laboratories around the requests for particular patients who might fall into that category as well, and also where, for example, you can, apart from dialysis patients or renal patients who are attached to dialysis machines, for example, or might be dialyzing, for example, 3 times a week. Some patients, unfortunately, have circumstances where they not only have renal issues or renal health concerns or kidney health concerns, but also hematological health concerns. So therefore, the category where these patients are under actually may prompt the use of red blood cell components to correct anemia and general hemostasis, as mentioned in the first slide set around this particular episode, where and therefore they patients in around where they're nephrology patients, they can become hematological patients, but can also become oncology patients as well. And it's very devastating in generally what can happen to individuals who have for example, underlying nephrology health issues. Albeit, that being said, it does also depend in part the etiology and the diagnosis of patients who are diagnosed with a form of kidney disease as well, where chronic anemia can be concerned or is concerned. Now, that being said, most hospitals again have what's known as a maximum surgical blood ordering schedule, and this was once upon a time referred to as something called MSBOS, and generally the transfusion laboratories have a particular quota on the number of red blood cells amongst other particular blood cell components or blood components, where there is a quota in place for different blood components, so that patients who need blood or blood components have the appropriate healthcare and response as and when particular blood components as part of their general physiology could be compromised. So most hospitals generally will have a maximum surgical sort of blood ordering schedule. If for example, let's say there are two patients in a hospital, and they both have the same blood group, but one patient's condition has more severity around the health concerns. So to the extent where unless they get particular blood group and also and potentially other components, then versus another patient or individuals who have the exact same blood group, etc., but yet the other patient could well be managed or looked after through sort of other alternative ways until for example until there are no other ways to respond. Is looked after, the patient is looked after in a way where, unless the hemoglobin drops even more so than the other patient who has the same blood group, then and only then, for example, that patient might for example need more serious attention in relating to hematology or transfusion response. Now, in these particular circumstances or these situations, what can happen, apart from what's known as a maximum surgical blood ordering schedule, transfusion laboratories and hematology laboratories, for example, in those particular circumstances, can actually request what is known as ad hoc blood or blood components, whether it's red blood cells or of a particular blood group type, or actual different blood components. Ad hoc can be requested so that patients can actually get the appropriate healthcare in emergency situations, or where to avoid emergency situations as well, where in anticipation more than anything patients on both from both perspectives, and both perspectives can receive the appropriate care as necessary. So I wanted to highlight this because the ordering schedule is actually something that transfusion laboratories, generally speaking, have a sense of proudness around, because it also highlights that health professionals on the front line cannot abuse a sense of a request where, for example, if again the hemoglobin, which is the main marker for where patients might need a transfusion, or red blood cells, for example, unless it drops lower than a certain point, then healthcare professionals on the front line can actually and will have to be informed by those working in those part of transfusion practices, to inform them that if the hemoglobin is low, but does not meet a certain cutoff, then actually there is no real necessity for scientists to issue blood. However, and just quickly, I will say that, for example, if the hemoglobin is low, and those health professionals who are on the front line, for example, anticipate that the hemoglobin will go lower or will drop lower, then basically at that point they through the request from Haematology or Transfusion laboratories, the procedure is generally they can request 1 unit of blood, whole blood or red blood cells, and at that time also monitor the hemoglobin to see if there will be any hemostasis change amongst in the individual who may require transfusion. So there's so I wanted to provide that perspective in around here, and then I also want to talk a little bit about how based on particular requests, how through particular requests there are several things that need to be additionally identified and established, and that is to say there needs to be an understanding around the pre-surgical condition, or the condition that an individual or a patient has. The age of a patient is important, and the overall sort of surgical procedure that a patient or individual may have to have. So generally, pre-surgical is where health professionals provide an understanding of the potential options that individuals or patients have in relating to surgery and where transfusion may be required. But then when it comes to actual blood loss, it's important for transfusion scientists and also those in hematology laboratories to know of the surgical procedure that the patient or individual is actually having. And then also in some contexts, retrospectively, and this would differ in laboratories depending on where scientists practice, is where some laboratories actually have information on requests relating to actual surgical protocols as well. So what this means is basically a plan or a procedure of where of the timeline in the run up to where a patient or individual might need transfusing. So these things or these entities are important and need to be established or identified as part of a a request for red blood cells. And in line with this, or in line with hemovigilance, really more than anything, is important. It's important to know that there is reference in guidelines around what is known as a cross-match to transfusion ratio, and that also is something that is established. So basically, based on someone having a cross match, based on the request for red blood cells, based on that, there is a number of red blood cells that can be issued at any one time. So generally speaking, for example, if someone has a low hemoglobin, and it's forcibly low, let's say, then in that regard, the cross match to transfusion ratio is where a cross match may be done then and there, or may historically been done, and therefore in a situation where the hemoglobin is really low, then basically the transfusion ratio or the request for red blood cells is higher, because of the emergency aspect that surround that particular incident. And generally, in transfusion laboratories, there are procedures that ensure apart from safe practice in and around transfusion, there is also there are also sort of procedures in place to ensure that health professionals on the front line again are either informed of that, but also where those on the front line cannot abuse the sort of request in and according to transfusion guidelines of practice, but also in relating to general hematology as well. Then there is also something that relates to the cross match and transfusion ratio. There is actually something that's known as the Transfusion Index, and that also needs to be established or identified, and that really refers to where, for example, again, where in relating to the number of requests around red blood cells being a requirement, there is also an index where for example again, if patients who have a necessity for a number of red blood cells to ensure that their hemoglobin is at hemostasis, then then there is an index, a transfusion index around in and around this as well. And so generally speaking, all transfusion laboratories have a particular quota, a quota around the transfusion index, and so this relates to also, apart from practice, safety and practice, safe practice, around transfusion laboratories. It is also where the transfusion index may differ. It may differ slightly or potentially variably, depending on where, depending on for example, depending on sort of population that that come through in and out of hospitals, or the hospital environment where patients might require transfusion. So the transfusion index has some variance around that as well. That being said, it's also vital to note that as I mentioned in a previous slide, I mentioned about the maximum surgical maximum surgical number of red blood cells or blood components that can be requested or organized at any one time. So an MSBOS is individual to a particular hospital. So this is a sort of an important point there. And then an MSBOS may also be individual to a particular surgeon. So some surgeons have different have different sort of quotas in relating to surgical procedures that may be going on within an area of specialty as well. Generally an MSBOS is and can be quite flexible, retrospectively, though it may be termed it may be termed a little bit different now. An MSBOS is also a live document, or was a live document in around transfusion laboratories, but now there are also other sort of procedures that are in keeping, or may well have replaced this particular sort of focus around transfusion laboratories, at least to some extent. In all other areas, including post-operative management of patients, there are a multitude of factors to be considered through clinical assessment, and before the decision is taken to actually transfuse. Now, those who are listening in on this sort of overview, generally speaking, in most part, believe it or not, whether from a surgical perspective or from a transfusion perspective, there is more done actually to prevent, in a good way, not to transfuse a patient, because what it is that patients who require transfusing can potentially build an immune response, which leads to a propagation of antibodies, and the antibodies can actually weaken the immune system more systemically, and so therefore the decision is to transfuse anyone, whether they have a sort of underlying sort of oncology issue, a hematological issue, a nephrology health concern. Generally speaking, the decision is one that is assessed and only at sort of worst, in some regard, in sort of worst case scenarios, will there be a request to transfuse. And the main aspect here is that hemoglobin, or the HB, is the main marker, to determine whether someone should be transfused. And generally, there is a sort of an agreed sort of cutoff. Anything above that particular cutoff, where the hemoglobin is concerned, cannot be there cannot be a request, or should not be a request, for anyone to be transfused. So to elaborate a little bit, these can include where, unless there is evidence of blood loss, evidence there is hemolysis, so there is systemically there are issues around a patient's or an individual's sort of red blood cells. There are issues around the cardiorespiratory state. There are issues around tissue oxygenation. There's issues around tissue perfusion. There is hemoglobin estimation. Something that's referred to as packed cell volume. So packed cell volume actually refers to where different components that make up not just red blood cells, but also in relating to what is contained in general plasma. If there is if there's compromise around the packed cell volume, then there may be a requirement for individuals to have particular blood components, if not red blood cells on their own. There is also the patient's ability to tolerate blood loss and anemia, and this is very important because in some incidences, so I mentioned in a previous slide, for example, there are issues, or there can be issues, where people on dialysis, or patients on hemodialysis, or a form of renal replacement therapy, the threshold around their hemoglobin can be higher, even if they lose blood, where there is evidence of blood loss. The threshold for that can even, as mentioned, there's a cutoff around hemoglobin, but even if the threshold is below that cutoff, there can be incidences where there's a patient's ability to tolerate blood loss, and blood loss and lower levels of anemia or hemoglobin than the actual cutoff. And this also is the way this is sort of sort of determined, as I mentioned also in one of the previous slides, is where there's the patient's age, which is important, but also the a patient's general health, in relating to their for example their cardiovascular system. So even with low levels of blood of even with levels of blood loss, the patient's ability to tolerate that blood loss can be higher, and therefore the anemia, though anemic, there's more tolerability around that. So now that I talked a little bit about that, I want to mention a little bit about um, how red cells are provided in relating to in following a request around someone who might have a low hemoglobin. So generally, and almost all red cells are provided in an optimal additive solution of what's known as saline, adenine, glucose, and mannitol, abbreviated as SAGM, or some laboratories generally refer to this as SAGM or SAGM, and it's basically the bag or the bag or of red cells that the components are actually are provided in, and these are the SAGM or the additive solution is actually at least from a sort of a UK perspective, there is a sort of sort of legislation in how these bags of red cells or any other blood components meet or are in line with the Medicines Health and Medicines for Health and Regulation Authority, or MHRA, and in keeping not just in keeping with the UK, but also the SAGM bags are in how blood components are issued and provided are in line and in legislation with European guidelines, and there is particular MHRA guidance around that. And all red cell components are now what's known as, generally speaking, as leukocyte depleted. So what this means is, if I can mention that previously in the previous slide, that for example, where I mentioned that when individuals or people want to donate blood, generally a part of the blood donation pack or the kit that is part of blood centers, where health professionals sort of support patients, or support donors who want to donate blood, as part of the kits that are attached, a part of the filters that are attached to kits, actually allow effective collection of red blood cells by actually sort of in some regard automatically depleting the red cell bag or whole blood, where there is no sort of infiltration of leukocytes or lymphocytes, i.e. what are known as white cells. So basically, all again, all red cell components are more or less leukocyte depleted. There will be in a later overview, I will talk a little bit about something that's referred to as irradiated blood, irradiated blood components. But for now, generally, all red cell components that come through blood donation sites are depleted of leukocytes. Now, the goals for preparation and storage of blood components are also several and important. So generally, it's important that there's the maintenance of and viability and function of each constituent. And what this means is basically where you have let's say, for example, your tissue, your red blood cell, your general red blood cell component. Within that red blood cell component, you have a certain percent. There's a certain percentage of other particular components. As I mentioned in a previous slide in this presentation or overview, one of the sort of photographs was where there was a separation between the plasma and the red cells. Now, basically, in one or several ways, that is done to actually maintain the viability and function of each component, each constituent around that red that bag. That sort of bag of blood that has been donated in one way. It also allows in some ways that once in some ways when blood comes through a main hub, for example, a processing or manufacturing department that actually looks at to ensure that what is being issued eventually to different hospitals, for example, are absolutely effective when and where, for example, a patient or individual actually requires that particular particular red cell or red blood cell component. So generally, the viability is important. And then there is the minimum. One of the other goals for preparation and storage is to minimize and prevent what is known as bacterial contamination and proliferation. And actually, in manufacturing and processing departments that deal with blood cells, red blood cell components on mass level, for example, basically the preparation and storage also allows those sort of departments to ensure that there is no bacterial contamination within blood that has been, for example, donated. So there are a series of processes that actually take place at other sites before, for example, red blood cells or platelets or fresh frozen plasma or cryoprecipitate. For example, there are a series of procedures that take place to actually minimize bacterial contamination, so that if and when a patient or individual needs components, particular blood cell components, then what happens is that the patient who requires them is not going to be compromised by having a sort of, or be at risk having a bacterial contamination through the blood that has been issued for them, requested for them. Then there is another, and one of the other goals in preparation around storage of blood components is to also prevent physical and chemical changes that are detrimental to the constituents. So this is in keeping with or is aligned to the previous point about prevention of bacterial contamination, but also physical and chemical changes, because generally with red cells, generally they in some regard, even when they're going through the process up until the point they're being issued to hospitals for donation, for issuing to particular patients with particular conditions, there can be the red cells themselves can be sensitive to particular changes. So, for example, as I mentioned in the first presentation around this particular episode about hemostasis, generally red blood cells, like other blood cell components, can be sensitive to things like temperature and changes in conditions under storage as well. So generally, these things are important as an overview. Then there is the shelf life. So again, shelf life, storage, and clinical indications for red cells are also important. And so, for example, here is a basic table that sort of highlights the sort of overview around shelf life, storage, and clinical indications for red blood cell components. Here, for example, there's something that's referred to as a packed red cells in a sagum bag. So saline, adenine, glucose, and mannitol. Generally, the shelf life in a packed sagum bag is about 35 around 35 days, and the storage temperature should be between 2 to 6 degrees, and generally the use around these packed cells in a sagum bag is for general transfusion. Then there is frozen red cell components, and the shelf life for those, for example, is different. They have to be used. Frozen red cells or frozen prepared cells have a shelf life of around 10. Have actually longer, of around 10 years, so a lot longer. And the storage temperature might be, for example, up to minus 80 degrees. And the use for frozen red cell components is that they are used for the prevention of non-hemolytic febrile transfusion reactions and rare blood bank conditions as well. So rare blood bank conditions. And then I will talk a little bit about irradiated irradiated sort of cells or red cells in a later in an overview later in this episode, a bit later. But suffice to say that irradiated red cell components have a shelf life of 28 days and have a storage temperature much like the packed red cells in the Sagan bag. And irradiated cells, red cells, are also provided or issued in Sagan as well, SAGM type bags as well. And the shelf life is 28 days versus 35 days. The storage temperature is the same, is 2 to 6 degrees, but irradiated blood is used for the prevention of what's known as graft versus host disease. And I'll talk about graft versus host disease a little bit later in a later slide set. Finally, as with the first overview in this episode, I provided a list of some references and acknowledgements, and I'm going to do the same here. So the context around this has been adapted from a textbook around hematology and transfusion from the International Society of Blood Transfusion, and it's the Science Series 2020, and it's a special issue around introduction to blood transfusion from donor to recipient, and it's available free online through the International Society of Blood Transfusion website. And I want to offer acknowledgement to Malcolm Needs, who is and was a transfusion scientist and practitioner in the United Kingdom, for the approach to hematology and transfusion as well. But also acknowledgement to Professor Ken Jones, who's an emeritus professor in immunology in the United Kingdom, for the immunological perspective around some of the immunological aspects and hematology that he has expertise around. So I hope this overview around the red cells has been informative. This is sort of part one around the use of red cells. There will be another overview or presentation around this as part of this series, part of this episode, and hopefully the presentations or overview in subsequently will also have more. There'll be more overview in other particular components around hematology, other types of components, and other aspects that are aligned to general hematology and transfusion. So I want to say thank you for taking the time to check out this overview, and I hope it's been informative. Feel free to use the timestamps on the YouTube through the YouTube channel. This will be on this YouTube channel, but also available on through a link on the Storm Robotics Instagram page, so thanks again, and hopefully look forward to providing another perspective on a more perspective on another area of hematology and transfusion subsequently. Thanks for tuning in.